بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. ما زلنا مكملين European Society of Vascular Surgery Guidelines for the Management of Descending Thoracic Aorta Disease, and today we'll talk about diagnostic methods in descending thoracic aortic disease. And in diagnostic methods, we'll discuss about the medical history and physical examination, plain radiography, transthoracic echocardiography, transesophageal echocardiography, CT angiography, magnetic resonance angiography, and PET scan, and the intravascular ultrasonography. And as regards the medical history and physical examination, a comprehensive medical and family history to delineate the risk factors as smoking, hyperlipidemia, hypertension, as we said before, and assessment of symptoms, and careful physical examination, including the blood pressure measurement and electrocardiography, the ECG, are required in all patients suspected of thoracic aortic disease. Patients actually should be examined for suspicious clinical signs such as aortic regurgitation, cardiac murmur, pericardial rub, signs of tamponade, and an expansile abdominal aorta. Presence of tamponade actually may be a complication of a type A aortic dissection. The diagnosis of thoracic aortic disease is based on imaging, and the choice of imaging modality should be based on the patient condition and the availability of different imaging modalities. So it is very important to do a comprehensive physical examination and to take a full medical history from the patient to delineate the risk factors and the family history. About the plain radiography, actually a posterior-anterior and the lateral chest radiographs can be used to diagnose a calcification within atheromatous lesions in the aorta, or a left pleural effusion, or an aortic enlargement with an increased aortic shadow and loss of the aortic knob, as we will see, and anomalous aortic contours in asymptomatic or even symptomatic patients. Presence of a left pleural effusion can indicate a frank rupture, an exudate from an inflammation of the adventitia in acute aortic syndrome, or less commonly inflammatory aortic disease. The International Registry of Acute Aortic Dissection, the IRAD, showed that 21% of patients with a type B aortic dissection presented with a normal chest X-ray. So we cannot depend on chest X-ray on all occasions. And the meta-analysis actually demonstrated sensitivity for an abnormal chest X-ray of 90%. So if there is an abnormal chest X-ray in the aortic region, there is a problem. But if there is a normal chest X-ray, no, you can miss the diagnosis of a thoracic aortic disease. Although chest X-ray might be used in a very low-risk patient to exclude thoracic aortic diseases, but actually these potentially lethal diseases require a conclusive diagnosis with the use of a multiplanar imaging techniques such as the CT angiography. And as we can see here, some examples of chest radiographs in patients with aortic anomalies. As we can see here, the presence of the aortic knob, and in the abnormal or in the dissection, loss of the aortic knob and widened mediastinal shadow, as we can see here also, and also in this chest radiographs. And as we said also, presence of a left pleural effusion is an indication of either a free rupture or an inflammatory process or an inflammatory aortic disease in rare occasions. As regards the transthoracic echocardiography, the use of TTE to assess the distal thoracic aorta is limited by structures in the thorax that weaken or distort the ultrasound signals and compromise the imaging quality. But actually via a suprasternal or a subcostal or a parasternal view, small parts of the distal thoracic aorta can be visualized due to presence of the bone. So some windows will show you the distal thoracic aorta, but in some places, or small parts of the distal thoracic aorta, descending thoracic aorta. While in the case of a pleural effusion, the back of the patient can be used actually for transthoracic imaging. The major advantage of a TTE is that it is non-invasive and can be used to visualize also the ascending aorta and the aortic arch and the supra-aortic vessels. In addition, the abdominal aorta can also be visualized to check for abdominal extension of the aortic dissection. During the TTE, all planes should be used to assess the extent of aortic disease and to exclude actually additional aortic or cardiac involvement. Because of its non-invasive nature and a wide availability, TTE is increasingly used in emergency department of community hospitals to screen patients suspected of having one or other acute aortic syndrome, such as type A dissection. And as we all know, the mortality associated with type A dissection is very high. So to have a modality to delineate this pathology early and to screen for this pathology early in the emergency department for patients presented with a chest pain is a very good thing to do and a very good thing to adopt in practice. However, the value of the TTE in the diagnosis of descending thoracic aorta pathology actually remains limited. In cases of examination limitations or inconclusive diagnosis, the use of additional imaging modalities is recommended. There are currently no specific studies to validate the usefulness of TTE for diagnosis of the descending thoracic aorta pathology, and we can see here in these photos one of the windows of visualizing the descending thoracic aorta actually delineated the presence of dissection, as we can see, with the true lumen and the false lumen. And this is the left ventricle, and this is the intimal flap or the dissection flap. So a type A aortic dissection can be screened and can be detected by the transthoracic echocardiography early in the emergency department. What about the transesophageal echo? In contrary to the transthoracic echocardiography, the transesophageal echocardiography can visualize the whole length of the descending thoracic aorta from the left subclavian artery till the celiac artery. So this diagnostic test is generally used as a second line imaging modality and is useful to differentiate between the acute aortic syndrome subtypes, which are the aortic dissection, intramural hematoma, penetrating aortic ulcer, with a reported sensitivity of up to 98% and a specificity of up to 95%. Transesophageal echo is an accurate diagnostic tool for aortic disease, providing a functional information in both the pre and, the most important thing in transesophageal echo, actually the intraoperative settings, as it can delineate the correction after correction of the dissection or something, how the true lumen is expanded, whether there is a flow or no flow in the false lumen after the intervention or no. So it can be used intraoperatively. The semi-invasive nature of the transesophageal echo has rare procedure-related risk, but it can cause a patient discomfort. So we cannot use the transesophageal echo as a screening modality as we said about the transthoracic echo, but we can use the transesophageal echo actually intraoperatively or immediate pre-operatively in an anesthetized patient or a sedated patient. So it requires a sedation, it causes a patient discomfort and is contraindicated in presence of esophageal pathologies. In the majority of cases, CTA scanning is performed as the first imaging modality, providing all required information. Transesophageal echo may be used in specific circumstances as a second line option, or it can be used intraoperatively, as we said. And as we can see here in this picture of a transesophageal echo, it can delineate the true lumen and the false lumen, and it can give us an idea about the flow within the true lumen or the false lumen. What about the CT angiography? CT angiography offers a detailed visualization of the entire aorta and its surrounding structures. It can actually distinguish between different aortic pathologies and is quickly and widely available. And over the last 2 decades, CT angio has become more sophisticated and is more readily available, with an increase in the number of scanners and the use of retrospective and prospective ECG-gated techniques to allow imaging with the systole and the diastole, and to allow imaging in different phases of the cardiac cycle. And through advances in even post-processing software, we can do a multi-planar approach to see the aorta from the sagittal view, the coronal view, or the axial views. These advances have resulted in motion-free images with a better resolution, reduced scanning times, and a better visualization of the aorta. Current CT angio scanners have a sensitivity of up to 100% and a specificity of up to 98 to 99%, with a slight variations between different descending thoracic aorta pathologies. Imaging should include a non-contrast study first, followed by an early and late phase contrast study, and should examine the part of the body between the thoracic inlet and the common femoral arteries, and this to delineate the whole anatomy of the descending aorta and to see the extension of the disease and to plan for the intervention. This range provides a complete information with three-dimensional reconstruction. In addition, dynamic images can further assist in surgical planning or endovascular interventions. Consequently, CT angio now has replaced the digital subtraction aortography as the gold standard for aortic imaging. Important disadvantage, as we know, of the CT angio include the use of nephrotoxic contrast agents and the exposure of the patient to the ionizing radiation. In patients at increased risk of contrast-induced nephropathy, circulating volume expansion with either isotonic sodium chloride or a sodium bicarb solution is recommended. And as we can see here, this is the Society of Vascular Surgery and Society of Thoracic Surgery reporting standards for type B aortic dissection. Aortic dissection is said when there is a tear in the intima that results in a separation of layers of the media and allows the blood to flow through two lumens, the true lumen, which normally the blood flows in, and in addition to this, and through the intimal flap to pass through the false lumen. What about the intramural hematoma? There is no identifiable direct communication between the true and false lumen, and it is characterized by a hyperdense crescent-shaped hemorrhage within the aortic wall, as in this photo. And what about the penetrating aortic ulcer? It is an atherosclerotic lesion that penetrates the internal elastic lamina of the aortic wall, but as we said, it does not penetrate through the adventitial layer to differentiate between the penetrating aortic ulcer and the pseudo aneurysm. As we can see here again, aortic dissection, the presence of the intimal tear or the intimal flap, which allows the blood to flow in a new lumen, which is the false lumen plus the true lumen. And in aortic intramural hematoma, there is no identifiable connection between the true lumen and this defect, but there is an increased density of the aortic wall without identifiable communication. Penetrating atherosclerotic ulcer, it is an atherosclerotic ulcer, penetrates through the aortic wall but with intact adventitia. As we can see here, a presence of intramural hematoma, as we can see here, the thickened aortic wall, and also the presence of penetrating aortic ulcer. And we have to know that penetrating aortic ulcer, aortic dissection, and intramural hematoma can interchange with time, or it can be considered as a dynamic process of the acute aortic syndrome. What about the magnetic resonance imaging? MRI has an excellent diagnostic capability that is comparable with the CTA and the transesophageal echo, and can be used for both preoperative planning and even for follow-up. A major advantage of MRI is that it offers a multi-planar evaluation with differentiation between different soft tissues. Moreover, MRI can provide additional dynamic imaging regarding the entry tear, flow, or arterial vessel involvement. Although the contrast is not usually required, the use of gadolinium actually enhances the quality of MRI, and as we know what gadolinium can cause, it can cause systemic nephrogenic fibrosis. MRI can be used to visualize the aortic wall in detail and is therefore more commonly used in patients with aortic wall pathologies such as the intramural hematoma or aortitis. Furthermore, the MRI does not require ionizing radiation and offers an alternative for patients with renal insufficiency, but in some circumstances. What about the disadvantages of the MRI? Limited availability and longer scanning times, which make it less suitable for critically ill or unstable patient. In addition, the ability of the MRI to detect calcification is decreased in comparison to the CT angiography, and artifacts from respiration or metallic implants reduce the image quality. And as we said, the post-gadolinium nephrogenic systemic fibrosis is rare but a devastating side effect in patients with impaired renal function. So using an alternative imaging modalities or using the lowest possible amount of gadolinium may prevent the nephrogenic systemic fibrosis. And as we can see here, an MRI of the descending thoracic aorta shows a type B aortic dissection with the visible intimal flap and compressed true lumen and expanded false lumen. What about the PET scan? PET is a nuclear imaging modality that is based on detection of increased metabolic activity in the inflammatory cells, resulting in increased uptake of gamma graphic traces, which is most commonly the fluorodeoxyglucose, the FDG. PET scan can be used in the diagnosis of aortitis. Very important to know that PET scan can be used for the diagnosis of aortitis and the assessment of the extent of activity of an inflammatory disease in the aortic wall. The diagnostic value of the FDG PET scan differs among various inflammatory aortic diseases, with a reported sensitivity ranging between 83 and 100% and a specificity between 77% and 100%. Although the availability of PET and PET CT is limited, this modality can be used for the diagnosis and follow-up of aortitis and inflammatory aortic diseases. Increased patient radiation exposure is a major disadvantage of the PET CT when compared with PET or CT examination alone, as the effective dose radiation is the combination of the dose for both scans, the PET scan, then the CT scan. As we can see here, the very good photo about the thickened thoracic aortic wall, and as we know, the inflammatory aortic diseases cause a thickened aortic wall, and in the PET scan actually we can see the enhancement of the aortic wall, and in this case of Takayasu aortic arthritis. What about the intravascular ultrasonography? It permits a 360 degrees visualization of the aortic wall, and it can be very helpful in confirming the intimal defects when CTA or the digital subtraction angiography are inconclusive in the diagnosis of aortic injury. And IVUS, we need to know that it is an operator and experience dependent invasive procedure, and the complete evaluation of the aorta using the IVUS can be time consuming. In some centers, actually IVUS is routinely used as an adjuvant imaging technique during the endovascular repair. And as we can see here, this is the photo of the IVUS. We can see the flap and the origin of the superior mesenteric artery. We can see the presence of the flap here and the IVUS catheter within the true lumen, presence of the false lumen, and the ostium of the left renal artery and the left renal vein position. And this table, we can see the comparison between the different imaging modalities for the descending thoracic aorta diagnosis. And as we said before, the gold standard now for diagnosis of descending thoracic aorta is the CT angiography. The transesophageal echo can delineate the whole descending thoracic aorta, and it can be used intraoperatively, as well as the IVUS, which can be used in combination with the direct digital subtraction angiography intraoperatively during the endovascular repair. And what about the recommendations of the guidelines? All patients with clinical suspicion of thoracic aortic disease and abnormal chest radiographs should undergo a CT angiography for diagnosis confirmation, and a multi-detector CTAs for thoracic inlet to the common femoral arteries should be considered as the first line diagnostic modality for descending thoracic aortic pathology. And for the diagnosis of descending thoracic aortic disease, a transesophageal echo should be considered as a second line imaging modality when the CTA is unavailable or contraindicated or inconclusive. And why the transesophageal, not the transthoracic? Because the transesophageal echo can see the whole descending thoracic aorta, and the transthoracic echo can see only a small parts of the descending thoracic aorta through the windows of visualization. For patients at increased risk of a contrast-induced nephropathy, a volume expansion with either an isotonic sodium chloride or a sodium bicarb solutions should be considered before contrast administration to try to guard against the contrast-induced nephropathy.